Hi, this is Sherry Shabowski, and today we're going to talk about atrial fibrillation with rapid ventricular response. Now, that must seem like an overwhelming concept for people who are new to medicine, but I promise you that learning how to deal with a medical problem will motivate you to learn the basics that lead to that decision. The actual question we're going to be asking is why do you need to think twice before you cardiovert someone with atrial fibrillation with rapid ventricular response? This can be a clinical conundrum, and you're really going to have to put your thinking cap on and use everything you know in order to make the right decision. Some important concepts you'll need to know in order to make this decision include what is normal cardiac conduction? On a cellular level, how does the action potential conduct? You'll need to know the pathophysiology of atrial fibrillation. I mean, what is it and what's it doing and why is it a bad thing? You need to know what synchronized cardioversion is. And then we're going to need to talk about risk benefit decision making. You have to know the risks and know the benefits and balance them and make sure that you're making the right decision for your patients. Well, here we have the heart anatomy. Yep, no one ever said I was a phenomenal artist, but here we have the superior vena cava bringing blood into the right atrium. It also comes from the inferior vena cava. Basically, top of your body goes to the right atrium, bottom of your body goes to the right atrium. That blood goes into the right ventricle. The blood goes to the lungs and gets oxygenated. That oxygenated blood goes into the left atrium, then to the left ventricle, and then it's shot out through the aorta to your entire body. Basically, that's how it works. Now let's talk conduction system. Let's start with the sinoatrial node, which is located in the right atrium. It has many tracts that send that electrical activity around the atrium and to the AV node. It goes from the AV node then to the bundle of His. Then it branches into the right bundle branch block and the right bundle branch and the left bundle branch. And that information is sent to both ventricles so that your heart can contract in one beat. For every time the sinoatrial node triggers a beat, the heart responds by beating all at once. This is basically an automatic process. The cardiac conduction system is automatic. The nodal cells trigger the conduction system, and the conduction system regularly triggers the contraction of the myocardial cells or the muscle of the heart. It's a good thing that your heartbeat is on autopilot. I mean, seriously. Otherwise, you would have died the first time you fell asleep. All right, let's look at the conduction system and how the information from the conduction system spreads to the muscles of the heart. You start with the all-important sinoatrial node. This is the pacemaker of the heart and set at a rate between 60 and 100 beats per minute. Once triggered, it instantaneously sends the signal toward the AV node, which then goes to the bundle of His, then through the bundle branches, and finally to the Purkinje cells, which are in the ventricles. The signal spreads across the myocardium and it contracts in synchrony. Can you imagine how fast that signal is promoted to cause every one of the more than 3 million cardiac cells to beat as one? Every second of every minute of every day of every year of your life? I mean, medicine is truly amazing, and it's well worth it to learn as much as you can about it. It's actually a lot of fun, and you can help people. Since your heartbeat is critical to life, it may not surprise you that the entity that made you hooked you up with a backup mechanism. Otherwise, even a temporary sinoatrial node dysfunction could be the death of you. The sinoatrial node is the pacemaker of the heart, and it's set at a rate between 60 and 100 beats per minute. If it doesn't fire, the AV node picks up the slack, but at a much slower rate. more like 40 to 55 beats per minute. If both of these nodes don't activate, the bundle of His or the bundle branches will kick in at a rate of about 25 to 40 beats per minute. I mean, that's not the greatest, but better than nothing. Basically, the fastest trigger wins. It overrides all the others and the heartbeats. And that is typically going to be the sinoatrial node or SA node. Now let's take a deeper dive to really find out how it all happens. Let's go to the cellular level. Here is a sinoatrial nodal cell. We're going to have to take a few steps back in order to move forward together. Cells have channels in the cell membrane that allow electrolytes to cross in and out. There are also energy requiring pumps that can actively transport ions and create an electrochemical gradient across the cell membrane, moving different ions across the membrane by active transport. Active transport means energy is used up to create this electrochemical gradient. These concepts are the basics for the discussion that comes next. All right, there are basically two types of cells in the heart: nodal cells and myocardial cells, and they are intimately connected. Let's start with the nodal cells within the conduction system and talk about how they work. The automaticity begins when a membrane channel allows sodium to slowly enter the cell. This is going to begin the slow depolarization of the cell. Remember, it started out very polarized at a negative 70 to 80, 60 to 70 millivolts. So you start out really, really, really in a situation where you have a big differential here. When the microvolts hit 40, that would happen because those sodium ions are sneaking in. That triggers the calcium channels to open, and this allows calcium to rapidly enter the cell, causing a rapid depolarization to plus 20 millivolts. So now you've gone from minus 70 to positive 20. That's depolarization. This wave of depolarization flows through gap junctions between cells that triggers the depolarization of adjacent cells. And there is a very rapid ripple effect that depolarizes the entire heart. Meanwhile, the sodium potassium pump, which again is active transport requiring energy, works then to reestablish the resting potential of minus 70 to 80, thereby repolarizing the cell. Here it is again in a stepwise fashion. That's a lot that I just did in one slide, so let's go again. The resting potential of the nodal cell is minus 60 to minus 70 millivolts. Automaticity is related to the ability of sodium ions to slowly influx into the cell. When there is enough sodium that's snuck into the cell, it'll hit a threshold, the microvolt threshold. And this will cause calcium channels to open and calcium floods in, causing the rapid depolarization of the cell. Once completed, the sodium potassium pumps repolarize the cell and have it ready for its next depolarization. That took so long to explain, and it all literally happens in a microsecond. It's insane. All right. This picture illustrates the rapid depolarization of all the cells in the heart triggered by the by the SA node. Now let's talk about what happens in the myocardial cells. The myocardial cells have a resting potential of approximately minus 90 millivolts. So they are super polarized. The depolarization wave comes from the nodal cells, triggering myocardial cells' sodium channels to open, and then sodium floods in and depolarizes the cell. There is then a transient outward flow of potassium to neutralize the electrochemical gradient a little bit. Now, the L-type voltage-gated calcium channels open, and calcium flows in to cause contraction of the myocardial cells. Ultimately, potassium flows out by way of the active transport pumps, and resting potential is reestablished, and the cell is repolarized. The nodal cells and myocardial cells are adjacent. When the nodal cell is depolarized, channels depolarize the adjacent cells, including other nodal cells and myocardial cells. That's that ripple effect I was talking about earlier. Depolarization of the myocardial cells triggers the calcium channels to open and calcium to flood in. Calcium activates cell contraction, and the concentration of calcium in the cell determines the contractile force. Contraction of your heart is an all or nothing phenomenon called cardiac syncytium. The heart contracts as a unit, or it does not contract at all. It does this by spreading the depolarization that starts in the nodal cells across the heart like lightning, or maybe even faster. The myocardial cells have intercalating discs that allow the action potential to spread simultaneously across the entire myocardium, leading to a synchronous contraction. I mean, seriously, you must admit that this is all amazing. Depolarize, repolarize, depolarize, repolarize every second of every day of your life, and sometimes double time. No breaks, no rest. Your conduction system is a beast. Here's a little fun with pharmacology. We discussed how the sinoatrial node is automatically triggered, keeping your heart beating without assistance. But the rate can be modified. This happens in several ways, but here we will discuss beta 1 receptors and calcium receptors that are along the nodal cell's membrane. Let's start with the sympathetic nervous system, which, when triggered, releases epinephrine into the circulation. Epinephrine has beta 1 properties that can stimulate chronotropic and ionotropic activity in in the heart. This means it can make the heart beat faster and harder. There are beta 1 receptors on the sinoatrial nodal cells that receive the epinephrine and trigger that node to go faster. Drugs with beta 1 activity can also increase heart rate in the same way. We need the heart to beat slower. Well, there are drugs that block these same beta receptors, and there are calcium channels that are also blocked. Using these medications slows the heart rate and reduces the strength of contraction, thereby decreasing cardiac output and blood pressure by making the cells less responsive to epinephrine. Some very clever person who understood this physiology created these blocking agents, which are used by millions of people. I mean, look what can happen when we truly understand physiology. This is genius. Now that we know how the heart beats on a cellular level, let's take a look at how it's measured. This is a normal cardiac cycle as seen on a cardiac monitor or EKG. The leads measure the alteration in electrical potentials as they move across the heart. This is how it's broken down. The P wave represents the depolarization of the atria initiated by the depolarization of the SA node. The isoelectric, or flat-lined, PR interval represents the depolarization of the AV node, which is a critical factor when we're discussing atrial fibrillation, so keep it in your mind. The AV node is a checkpoint where the transmissions are transiently delayed before depolarization of the ventricle. This phase is mechanically associated with the contraction of the atria. The QRS represents depolarization of the ventricles. Atrial repolarization occurs at the same time, but it's not obvious on the EKG because it's at a much lower threshold, so it's eaten up by that QRS. The isoelectric ST interval corresponds to the isovolumetric contraction of the ventricle. When the piece of the myocardium is damaged, this isoelectric period is disrupted, causing ST changes seen in ischemia. An example is a STEMI, which stands for ST elevation myocardial infarction, or the EKG equivalent of a heart attack. Finally, the T wave represents the repolarization or cardiac relaxation, which mechanically responds to the filling of the atrium again. You might want to pause here because this is a little tough to ingest this quickly, and you're going to need to understand it as we move forward. All right, you may have some sense of what an AED is. AED stands for automatic external defibrillator. They're everywhere now, so you've probably seen them even if you didn't realize it. Defibrillation delivers a blast of electric current randomly to the cardiac conduction system that is not at that time generating any cardiac contraction. This is called ventricular fibrillation. The idea is that the defibrillation will shock the heart's conduction system back into a normal rhythm. That's what it wants to do. It wants to be in a normal rhythm. So giving it that shock, it'll start back up the way it's supposed to. Assuming that if the conduction system is shut down by the shock, the nodal cells will reset and the normal conduction will be reestablished. I mean, it is the default for the conduction system. And if this is not the ultimate Apple genius turn it off and turn it on application you've ever heard, please enlighten me. Atrial fibrillation is a dysrhythmia, and depending on how fast it is going, it can cause the patient to have significant distress. But realistically, at least they're still alive. So, as in any situation where you can make the situation worse, you're gonna need to think it through and potentially make some adjustments before you go to your decision. Defibrillation stops the heart. If you defibrillated someone with a perfusing rhythm, you could shock them into a more dangerous and non-perfusing rhythm. Really poor form in everyone's opinion. Luckily, the machine has an alternative setting, and that is called synchronized cardioversion. It still stops cardiac conduction transiently, but because the machine is synchronized with the QRS on the monitor, it is significantly less likely to cause that more dangerous non-perfusing rhythm. Also, the amount of energy that is used in the shock is modified and typically much lower when the patient is perfusing. How do you remember? Well, if the patient has a pulse, you have time to adjust the settings, right? If they are in cardiac arrest, there's really no time and no need to modify the machine. Just go. Luckily, the machines these days will analyze the rhythms themselves before they shock, so it's less likely for you to make a mistake. All right, now what is atrial fibrillation? We've gone a long way to come back to the original question. Atrial fibrillation is a disruption in the supraventricular conduction system that's above the AV node. But it's typically moderated by the AV node, so it does not overwhelm the ventricular system. It is a lot of work for the AV node, but the AV node holds strong. Nodal cells are triggered randomly in the atria at rates that might exceed 300 per minute. If the ventricle beat at that rate, it would never be able to fill and immediately fail. Thank God the AV node holds the line and protects the ventricle. You may or may not know, but the coordinated rhythms, the atria contract to fill the ventricle with as much blood as possible. What I'm saying there is the atrium can actually contract and push the blood that's in the atrium into the ventricle. The atria in this case is just basically wiggling in response to all that uncoordinated stimulation. So you're not going to have that push of blood into the ventricle. This is a key issue with chronic atrial fibrillation, as there is an appendage in the left atrium that blood may become stagnant in, and this may lead to a clot. All right, let's give this little guy some help. The AV node has proven to be able to block insanely fast atrial electrical impulses. It turns out there are beta blockers and there's beta receptors and calcium channel located in the AV nodal cells too, just like they were in the SA node. So, medications like beta blockers and calcium channel blockers can increase AV nodal tone, strengthening your AV node and reducing the ventricular response to an erratically firing atrium. You can use them if they're not otherwise contraindicated. That is a little beyond this talk. This is called rate control as opposed to rhythm control. The atrial fibrillation continues, but the heart beats at an acceptable and safe rate. At what point does the theoretic risk of a stroke exceed the risk of the hypotensive patient with active chest pain? You may or may not know that very rapid AFib with RVR can degrade into ventricular fibrillation, which means the heart might completely stop pumping. So if you have a patient whose heart rate is so fast, let's say 180, 200, caused by the atrium, well, at that point, you're going to need to do something because that's not going to generate enough blood pressure. And the person is going to get chest pain and they're going to feel really bad. So, yes, you don't want to shock the clots into the brain and cause a stroke. That's for sure. But that's a theoretic risk. And the person is like actively dying in front of you. So, when does the risk to life in front of you exceed the theoretic risk of stroke that will allow you to cardiovert atrial fibrillation? Well, the answer is when you have no other choices. I mean, in this case, beta blockers and calcium channel blockers can't be used because the patient is already shocky, they're hypotensive, and they have chest pain. And electricity works. So, what's it going to be? Perhaps it occurred to you that if we anticoagulate the patient, then shock them, we should be good. Nope. The way anticoagulation works is that it blocks further clot formation and allows your body to dissolve clots naturally. And unfortunately, this takes quite a bit of time. And this guy is hypotensive and having chest pain right in front of your eyes. This is just reality. Does the thought of making these decisions excite you? Maybe you're an ERMD in the making. Or maybe you aren't going to be a decisive surgeon. Does it scare you to make huge decisions based on limited information? Then perhaps you are destined to be a specialist. No shade on specialists. There are jobs in medicine that fit any personality, and I have helped guide hundreds of medical students into the profession that suits them best. All right. I hope you felt like you learned a lot here. If so, please follow me on Facebook and please like and subscribe to my YouTube channel. It will definitely encourage me to do more lectures. I am an emergency medicine MD with more than 30 years of experience in medical training. I am now retired, but I don't want out of medicine. I love medicine. I have trained thousands, and I do not want to let all that experience fall out my ears. I recently began teaching a post-baccalaureate college program, training students who want to pursue medical careers. I absolutely love it, and my students have given me so much positive feedback that I want to share it with everyone who's interested. I have recently developed an educational website, and I am hoping you will be interested in my teachings. Everything I offer is basically encompassed in this one video. I have a basic organ systems course for people who are early in their studies. I have a comprehensive series reviewing every organ in the body, which will make you more knowledgeable about the body than 95% of the world. I have a medical decision making primer to help you make those big clinical decisions like the one in this video. Please consider learning with me. Check out my products at www.medicaleducationinminutes.com. I would be very encouraged by your support. Medical Education in Minutes also has a Facebook site and a YouTube site, so please again follow, like, and subscribe to motivate me. I definitely do not need to keep working. I have a nice pension, but I really want to help train the next generation. I mean, I may need you. Thousands of trainees have benefited from my training and tell me that they hear my voice in their head when they're making difficult clinical decisions. I want to help as many people as possible before I cannot. Let me utilize my 35 years of experience as a physician to help you get ahead of the competition. Your support will keep me posting. All right, I hope to see you next time.